Chairman and members of the committee, thank you for the opportunity to present today on legislation that I plan to refile in January. I'd like to briefly walk through how we arrived here, what we accomplished last session, and where this legislation stands now. 5 years ago, Representative Bentley introduced legislation to ensure Kentucky's pharmacists were reimbursed for providing clinical services they are already authorized to perform. The General Assembly passed that measure, which secured commercial insurance reimbursement, but it did not bring Medicaid into alignment. Last session, I filed House Bill 3 to address this gap. At that time, there was uncertainty about potential Medicaid federal changes, and the Cabinet raised concerns about possible costs of implementation. To continue moving this issue forward, Senator Richardson and I shifted strategy, and Senate Joint Resolution 26 was enacted. SJR 26 directed the Cabinet of Family and Health Services and the Department for Medicaid Services to report to the LRC on House Bill 3, including potential costs, impacts, savings, and access considerations, using evidence from other states where pharmacists are reimbursed for these clinical services. The Cabinet submitted that report on August 1st. Their findings were clear. Implementation would require only moderate administrative adjustments with minimal upfront investment, such as updating software to add billing codes. Pharmacist-provided care for minor ailments is often significantly less costly than other settings while improving access to care and health outcomes. Patients treated by pharmacists for minor conditions receive equally effective care as from other providers, and pharmacists' involvement has been shown to improve chronic disease management for conditions like diabetes and hypertension. I am once again working with Senator Richardson and the Kentucky Pharmacists Association to refile House Bill 3 in the 2026 regular session. I might add that during the 25 session, there was no opposition to this bill. This legislation is very straightforward. It does not expand Medicaid, it does not expand pharmacists' scope of practice, and it does not add any new services. It simply ensures pharmacists, like other non-physician providers, are fairly reimbursed for the services they are already authorized and are providing. This bill is about fairness, cost savings, improved access, and better health outcomes. It also contains language to ensure flexibility should future federal changes occur, so Kentucky is not locked into unintended obligations. Before I turn it over to our pharmacists, I respectfully ask for your support of this legislation in January. With that, I'll invite Ben Mudd to share further specifics from the perspective of Kentucky pharmacists.
Thank you. Good morning. My name is Ben Mudd. I'm a pharmacist and the executive director of the Kentucky Pharmacists Association. Thank you, Chairman and committee members and our legislative sponsors for allowing me to speak today on behalf of KPHA and several of my pharmacy colleagues that are in the room with us today. Today I speak for all three major pharmacy organizations in the Commonwealth and on behalf of our whole profession when I say that payment for pharmacist clinical services is our highest legislative priority. As Representative Neighbors stated, and simply put, her legislation ensures pharmacists can be paid for clinical services that are within our existing legal scope of practice, because unlike other non-physician providers who are currently being paid for these exact same services, Kentucky pharmacists are not. Ensuring Medicaid reimbursement for pharmacist services will expand access to care and improve health outcomes for Kentuckians. As you all know, Kentucky faces many healthcare challenges. Based on existing data, which was referenced earlier today, our state ranks 46th in preventable hospitalizations and premature deaths. And access to care is especially limited in our 107 Kentucky counties that are designated as health professional shortage areas. Pharmacists are uniquely positioned to fill these gaps, with 119 of Kentucky's 120 counties having at least one pharmacy Pharmacists often are the most accessible healthcare provider in their communities. To make this point further, the Senate Joint Resolution 26 report identified 18 counties that have the least access to care. In those counties, there are 44 existing pharmacies that can provide much needed new access points. Pharmacists providing clinical services within their existing scope, services that, again, Medicaid already pays other non-physician providers for, does not expand our Medicaid roles. It does not make existing patients any sicker. It simply adds another group of providers, and a group that is often at a lower cost than some other existing options. As you all know, Kentucky Medicaid continues to face new cost challenges, and we recognize Kentucky's continued need for better health outcomes and overall improved health of our population. Pharmacists are positioned today to help address these challenges and to meet our patients' needs without reinventing the wheel. As the committee is aware, Medicaid and K-CHIP beneficiaries are particularly high-risk individuals, many of whom already see their pharmacist 10 times more often than they see other healthcare professionals. Pharmacists are extensively trained to manage medications, provide preventative services and education, provide treatment for minor ailments, and to collaborate with physicians to optimize treatment for chronic conditions to achieve better overall health. To give some examples of these clinical services that we're talking about, many pharmacies use what are called Board of Pharmacy Authorized Protocols. These are protocols that already define the care that we can provide under certain conditions within our legal scope of practice. These protocols act as guardrails to ensure that pharmacists' provided care is safe, it's effective, and following clinical guidelines. Board-authorized protocols include test and treat services for conditions like flu and strep throat, reducing costly and unnecessary visits to emergency departments and urgent treatment centers. But beyond community pharmacies, which you may all be familiar with, we have pharmacists working in hospitals and clinics that are well positioned to assist with the disease prevention and management, as well as medication optimization. My fellow pharmacist and former Representative Danny Bentley championed legislation in 2021 to ensure that payment for these services are paid for in the commercial market. However, as Representative Neighbors mentioned, we still are not aligned in Medicaid. Due to the populations most widely served by pharmacists in the state, payment for Medicaid is necessary to maximize the value that our pharmacists can provide to our communities. All of these comments and statements are based on real data. Numerous reports exist to support such a change. The Senate Joint Resolution 26 report itself reviewed 23 studies and highlights the potential benefits to our healthcare system in the Commonwealth based on the data and results that have been demonstrated in 36 other states who have already passed similar legislation, requiring Medicaid programs to pay pharmacists for services, again, within their scope of practice that they are already paying other non-physician providers. The changes needed to implement this legislation, should you all choose to pass it, are not complicated, nor are they different than any other routine adjustments that the Medicaid program does virtually every year. It will require a state plan amendment, also known as a SPA, that other states have already submitted and had approved, and it will require the Cabinet to set up new codes for billing within their existing computer software. The legislation as drafted would be contingent upon approval of that SPA by CMS and is worded to ensure that, should any future changes to Medicaid occur at the federal level, the Kentucky Medicaid program will not be locked into unintended obligations. On behalf of the pharmacy community and the more than 5,500 pharmacists and your constituents, we ask that you support and pass the return of this legislation in 2026. I'm proud to be joined today by one of my colleagues, Courtney Kugler, a clinical pharmacist with multiple board certifications and to offer a different perspective as a pharmacist working in a Kentucky health system to share more about the impacts of this legislation. After her remarks, we welcome any questions from the committee.
Thank you, Ben. Good morning, all, and thank you for the opportunity to speak. My name is Courtney Kugler. I'm a residency and fellowship trained, dual board certified family medicine pharmacist. Medicaid payment for pharmacist services would not only transform access to care in independent and chain community pharmacies across the state, but also in health systems like mine. I work with and am counted on by over 40 family medicine physicians to optimize and manage medications for chronic conditions like diabetes, hypertension, hyperlipidemia, anxiety, depression, smoking cessation, and more. I'm fortunate to practice in a clinic with an outstanding interprofessional team of nurses, dietitians, respiratory therapists, clinical social workers, and counselors. We all provide critical services for our patients, but I am the only one on the team who cannot bill Medicaid for the work that I do. Pharmacists complete doctoral training, residency programs, and often multiple board certifications. Every day, patients and providers trust us as the medication experts to evaluate, adjust, and manage treatments in accordance with our training and our existing scope of practice. Yet, we are not compensated by Medicaid for these services, even though other providers are paid to do the same things. Here's what that looks like in practice. In the heart failure clinic, pharmacists manage guideline-directed medical therapy, which helps improve symptoms for patients and keep them out of the hospital. Other providers can bill for these exact services, but pharmacists cannot. In diabetes clinic, pharmacists educate patients on this disease. We titrate insulin, interpret continuous glucose monitor reporting, and adjust medications to keep patients safe and improve glucose control. Other providers can bill for these exact services, but pharmacists cannot. In specialty clinics, pharmacists help manage chronic medications so providers can focus on acute or complex care. This expands access and shortens wait times for our patients most in need. Again, other providers can bill for these services, but pharmacists cannot. The result is that care is often routed to other providers, even when the pharmacist is a trained professional willing and able to do the job. Studies consistently show that when pharmacists are included in the care team, outcomes improve, hospitalizations are prevented, and overall healthcare costs go down. Ultimately, recognizing pharmacists as providers within Medicaid would not add new costs. It would unlock an existing, highly trained workforce to improve patient care, expand access, and lower costs across the healthcare system. I urge you to support Medicaid payments for pharmacist clinical services. Thank you.